unlike Dr. Gibbons, I'm mostly a clinical doctor. I'm not a geneticist. I'm working in patient clinic and seeing patients. And what I always want is to have clinical data and know something about rare diseases to help the patients I see. But in every rare disorder, it's often so that there's limited information available. There's limited detailed description of the medical aspects of rare syndromes. And it often leads to many questions. And what we do as medical doctors, we look in the medical literature and we search for information, but also for ATR-x syndrome, most articles in the medical literature are reports of case reports or studies focusing on specific syndrome, for example, genetics or gastrointestinal problems. And that's why it's really important to study the natural course of a disease, especially a rare disease. And in studying a natural course of a disease, you make a detailed description of a genetic disorder without having any treatment. So you describe how which symptoms these patients have and how their life goes. I performed studies like that in 2 other syndromes before Marlene came to me and said, well, I have funding, which is not how it usually goes, and could you help us with studying the ATR-x syndrome? Because the knowledge of the clinical symptoms is essential. You need awareness, you need doctors who know the clinical symptoms, doctors who know the disease, also to make earlier diagnosis and to search for ATR-x syndrome in this case. Of course, clinical data are essential to optimize care for the individuals with ATR-x syndrome and also for the caregivers because they have many questions. And before developing a therapy, you need to know how the course of the syndrome is without treatment. And that's why you need to gather the medical information. And as you know, as a parent, parents are always the best experts in the disease of their child. So that's why we brought all those knowledge of the parents together with the medical data. And we started in the Netherlands, and we did that in 2019. And we had 22 participants in the Netherlands. And they were between the age of 2 and 68 years old, with an average age of a little over 20 years. And what we did, we asked all the parents to fill out extensive questionnaires. We always have loads of questions, and all parents helped us very much and filled in these questionnaires very well. And after that, we had 2 students who did home visits and came to the families and their homes, Anne and Aruj. And they together they looked at the questionnaires and they asked more questions to the parents in interviews, and they also had access to the medical records. So they went to the hospitals and to the general practitioners to look into the medical records. And finally, they also did physical examination on the patients. And we met all these great boys and men, because as you can see on the bottom, we also had some older patients with ATR-x syndrome in this study, and we learned a lot about them from them as well. And we had an increase in knowledge, and we spoke to each other in the Netherlands, and we learned that we learned a lot of the study, and that's when we decided together again with the ATR-x Syndrome Foundation to expand the study and to do a worldwide study as well to gather more clinical data. And we did that web-based with online questionnaires. Unfortunately, it was not possible for us to go all around the world to see all the patients as well. So it was web-based, and we did the questionnaires online. And finally, we had 81 participants worldwide. So we were very happy with that. And 2 girls participated as well, and their parents filled out the questionnaires as well. And they were aged 0 to 44 years old with an average age of 12 and a half years. And that's what we see a lot in research. If you perform research, that there's a lot of the time you have some younger children. And if you go to patients at home and you actually actively search what we can do in the Netherlands, then you usually have the older patients as well. But they're very difficult to research. And these patients were from all over the world, as you can see in all the countries. And when we then look at the characteristics of ATR-x syndrome, Dr. Gibbons told us about it in the previous talk. We first saw that the alpha thalassemia was not recognized in so many patients. It should be there, as we were told, in about 75 to 80% of the patients. Of course, in the questionnaire-based study worldwide, we could only ask for anemic symptoms and could not look at the blood results ourselves. And there was 22% of the parents who reported alpha thalassemia or anemia. And in the Dutch patients, we found that only in half it was investigated, and in 30% alpha thalassemia was found. So that's far less than you expect. So we found that remarkable. What we found was that all patients had an intellectual disability, and it was a spectrum of intellectual disability. So the majority had a severe to profound intellectual disability, where there were only also 20% of the patients who had a moderate intellectual disability, and they could sometimes speak sentences and function a bit higher than the other children. And the facial characteristics, of course, we could only look at them in the Dutch population. And we saw many similarities, as you can also see today and this weekend, but also differences. And what was remarkable is that a few of the older men have less characteristic facial features than the younger children. The first signs reported by the parents, we saw that over 1/3 of the parents had concerns about the functioning of their child in the first days after birth. So that's a lot. And on average, about after 3 months, there were serious concern about the children. And the main first symptoms were, of course, feeding problems, delayed milestones, floppiness of the children, and some recognized characteristic facial features, and the lack of interaction was a trigger for many parents. But what we also saw was that the diagnosis was often made for later, between 6 and 7 years old, with a range of 0. With some children have a brother with ATR-x syndrome, and then of course diagnosis is often early. But the range still 42 years of age. And that the diagnosis is made many years after the first concerns by the parents. And in the Netherlands, it was remarkable that 6 out of the 21 participants were diagnosed in adulthood. So that's rather late. Of course, this is a sort of new disorder. So we only know about ATR-x since 1990. And nowadays, still genetic variants are found. So we have to learn a lot more. And hopefully in 10 years, the diagnosis will be far earlier. But yeah, still it's today not easy to get the diagnosis of ATR-x syndrome. Here you can see some data on the development. We asked all parents if their child achieved these separate milestones, and what the age was at which they achieved the milestone. And you can see that almost half of the patients learned how to walk, and often it's later than you expect in a regular population. But we also know that there are some children who start walking at around 7 or 8 years old. So that's important to know that the development can take longer. There are some children who never learn to walk. There are other children who walk very well. So that's a spectrum you can see in ATR-x. And I wrote more about this in the report, so you can read it at home. But it takes too much time to tell you everything. Behavioral problems were unfortunately very common. Over 80% of the parents reported behavioral problems in their children. And what we saw was that biting was a problem in many children. Manic behavior, restlessness, very active children, hitting, scratching, pinching, episodes of crying were reported often, and also aggression to itself, like pulling hair and head banging. And what's very important is that most of the children cannot communicate well. And what parents report was that most often this behavior came when a child did not feel understood. And that's why it's important to look for ways to explain to the child what is happening. So have a structure in the day, and also look for a communication tool, what helps them to express themselves. Because they're not mean children, but they often show this behavior because they have the frustration and cannot communicate. Problems with sleeping were also very common. In over 70% of the children and adults, there were problems at night. For example, waking up at night, not being able to fall asleep, very restless, and also stops in the breathing were reported. Unfortunately, this improved with aging in the majority. In 38% we saw improvement, and in 21% even the problems completely disappeared. Medication was often tried, and there was also a research project by Kempenhagen, and most of you participated in the study as well, of the Dutch parents. Most often melatonin was tried, but all the medications had limited effect, so it's not unfortunately, it's not easy to help in these sleeping problems. Epileptic seizures in almost 30% of the patients. The average age of start was 6 years. And most frequently they had tonic-clonic seizures with the jerking movements, or absence seizures. That's shorter seizures where they stare for a few seconds and afterwards resume what they started. But almost 40% of the participants and their parents report that there were seizures without EEG abnormalities, so that they can be labeled as epileptic seizures. But in these seizures there were also jerking movements, staring, periods of being non-responsive or having respiratory problems. And that's a big problem, and we don't know yet what the origin of these seizures is. So I hope in the future we can do more research in what the origin of these seizures is and how we can treat it and help these boys and girls. Visual problems were found in over half, but we didn't find structural eye disorders. It was usually refractive disorders or squinting what we saw, and the majority, a little less than the majority, wore glasses from an average age of 4.5 years old. As you can see here with this nice boy in the picture, he grew a lot, I saw today. He's not this tiny boy anymore. Hearing problems were reported in far less of the patients, and 2 participants used hearing aids. We heard a lot about the gastrointestinal problems earlier with Dr. Gibbons, and he explained also the origin of these problems. Easy for me, so I don't have to explain anything about that. But as you know, these problems are very common in boys and girls with ATR-x syndrome. Over 70% of the patients reported feeding problems at the moment of the study, and mainly trouble with the swallowing and trouble with the chewing. And it's important to look for the most safe way to eat for the boys, since if you choke you swallow your food the wrong way, you are also at risk for pneumonia. That's of course we don't want that. In more than half of the patients there are periods of not eating and drinking. Of course very troubling if your child is not drinking at all. And almost 25 of the patients sometimes require hospitalization for fluids since they stop eating and drinking. In many cases it's not really possible to find why the periods exist, But what we always have to look for is pain is a trigger for stopping with eating and drinking. Constipation is a very common problem, and other illnesses. And of course, you always have to be aware of the gut problems that can exist in ATR-x syndrome. Fortunately, usually it's not such a good problem as the volvulus and the problems Dr. Gibbons also explained, but you also have to be aware of those problems, and you need doctors who know about these problems. Yeah, other gastrointestinal problems that are frequent and we already talked about is reflux, disturbed gastric emptying, where food cannot leave the stomach adequately, constipation, and we also had some patients who had gastrointestinal bleeding. So it's also important to be alert. What we found is that over 30% of the parents told us that their child had some food allergy or intolerances. So it's also important to be very keen on that. And as Dr. Gibbons also told you, there are some products in the food that make that there's more air. That fermentation is in the gut. And so it's good to look at which food your child takes, and sometimes it works if gluten or soy are eliminated from the diet. So it's important to be alert. Cardiac defects were mentioned or found in the medical records, if it were Dutch patients, in 35%. And often these were defects in the septum, so that's the a small hole in the heart, as they tell you. Respiratory symptoms were also found in almost a third of the patients, and usually symptoms like wheezing or moments that they stop breathing for a few seconds and then start breathing again. And what was remarkable is that 1/5 of the parents reported that their child needed more time to be fully awake after general anesthesia. So that's important to let the anesthesiologist know when your child has ATR-x that they have to take more time to let the child fully wake after surgery. What most of you know, of course, is that the majority of the boys with ATR-x are less tall than their brothers and sisters. We saw growth retardation in the majority. And what we frequently saw was deformations of the spine, over 50%. And what we unfortunately also saw in many adults was that there were severe deformations of the spine and no follow-up in childhood. So it's really important to especially before puberty and during puberty, that there's an attention to the spine. You can early help these children by adjusting the wheelchair or by using a corset to fix the spine so the scoliosis get less severe. That's really important as well. We found that some of the boys had spontaneous fractures of bones. And also that in who had the investigations, we found that they had osteoporosis. So that's less strength of the bones. So it's important to pay attention to that. And two important ingredients for the bones are calcium and vitamin D. So it's important from younger age to take that into account and to look if this is enough. And in the Netherlands we don't have enough sun, so most children need vitamin D. So it's important to have that in mind. We also saw other deformations in the feet and in the hands that were very common, and you see some examples of that in the pictures. Another finding that we did not expect at all was that we asked all the parents to give us a list of the medications that the children were using, and 11% used thyroid hormone. And we didn't ask further because we didn't expect so many children using thyroid hormone. So we think that's an important aspect to look into further in the future. Since this can also cause symptoms of weight gain, constipation, fatigue, and it can easily be fixed with the use of thyroid hormone. We also wanted to learn more about aging in the patients. Unfortunately, we had limited older participants, what's usually the problem in these kind of studies, but what was really clear was that with aging, the problems, the health problems were less in these patients. They had less behavioral problems, less sleeping problems, and fortunately less gastrointestinal problems. We saw that it decreased with aging in almost all patients, fortunately. In the older individuals, we investigated. We had some men in the Netherlands who were in their 60s. They complained of having more trouble with walking and standing. So that's something we have to learn more about, how to preserve these motoric functions in adulthood. They walk slower and more unstable. So we have to learn more about that. We also, of course, wanted to know the causes of death in the patients. We had 8 participants who died during the study, and of them, the majority died of an aspiration pneumonia. So that's really, one of the main causes of death in these boys. And 2 died of another infection, sepsis. They died between the ages of 2 and 36 years old. And based on these few patients, we're not able to know the life expectancy. What we know is that we also had patients in the Netherlands who were for over 60 years old. So it differs in the patients. I skipped the few slides because I told you also already about that, and it's also in the report, so you can read it there. I have the last bit of the psychosocial consequences, and I think that's important to know as well, and to be aware of as well, because caring for individuals with ATR-x is of course very burdensome. You all know the worries you all have in taking care of your child with ATR-x, and it has great impact on not only the parents but also the whole families and the other caregivers. And the care we give also as medical doctors is usually only focused on the medical issues. And that's why we looked further into the psychosocial consequences for the parents, and we ask you to fill out the questionnaires about, for example, anxiety and stress as well. And eventually 58 parents and 3 grandparents of 78 children participated. And today I will give you the first results. And what we found is that 52% of the ATR-x mothers and 25% of the fathers reported clinically relevant anxiety. 25% of the mothers and 12.5% of the fathers reported clinically relevant depression symptoms. And 10% of the mothers and 12% of the fathers met the criteria for PTSD. And what we found as main issues also for the parents was difficulty receiving support from people around you, and of course a lack of understanding of the situation by other people. And I think that's very, very familiar for all of you. And very troubling. And I think that's very serious, and the psychosocial consequences are serious. And what we also saw is luckily most ATR-x parents have sufficient adaptation and resilience skills, but it's important to also focus on the psychosocial consequences and be aware of the worries these families have, because it's also helpful for the entire family to have the support. And that's why I want to conclude as well. This weekend's, of course, very, very nice. And it's great for Marlene and all the other organizers that you're all together and you can all share your worries with each other. So take care of each other and have a great weekend all together.